and it's really lovely to be here. Thank you, Dean Washington. I call her early. We met as we're both advisors to the Fetzer Institute, on showing examples of love and forgiveness in healthcare around the world, and Early is a shining example of love and forgiveness in healthcare right here in Kalamazoo. And I was really blushing listening to your introduction, Linda. I wish my mother could have heard it, because that's who really appreciates these things, and that's the only one who believe it too. But I really thank you, and it's been wonderful to work with you and your leadership in Michigan, and helping as people did all around the country to do what finally was secured Tuesday, which is to have a clear path to make a government guarantee of affordable health care to everyone in this country just around the horizon. So what I thought I would do this evening with you is two things. One is, as the promo for this lecture this evening, as Linda talked a little about is how do you make change from the grassroots in this country? And I'm going to do it just through two examples that will illustrate the strategy and the people behind the strategy and give you a sense of what we did. And then what I thought I would do is talk a bit about the Affordable Care Act and what it's going to look like, why I think people don't understand it, what in very simple terms it'll mean, touch just a little bit on the issues that the government in Michigan's going to be addressing, and then we'll take questions. And I've been doing a lot of this around the country, and the wonderful thing is that the questions just keep coming. So I want to be sure we leave lots of time for that. I'm going to take my watch off so sure I don't go on too long, and we do have time for questions. So, as Linda said, HCAN, Healthcare for America Now, was this huge grassroots coalition that we built to pass healthcare reform. We started laying the groundwork for it actually in 2005, in some ways in 2003 in an article I wrote. And then we started building it in 2007. So it took a lot of work and a lot of preparation, and we were able to put together a coalition of major forces that organized people around the country that shared a set of values and a vision for healthcare reform. And we always understood that there was no way we could win this inside the Beltway. I mean, the last ad we did, we had enough money for TV ads as well as organizing. We're thanking members of Congress for voting. We said, thank you for standing up to the 2023, I forget the exact number, health insurance lobbyists. That was just the health insurance lobbyists. And we always knew that the money, the lobbying influence that the insurance industry and others in the medical industrial complex would have would be such that we couldn't win inside the Beltway. But we could do enough there to be a voice. Where we could win is outside the Beltway, where we would move the hearts and minds of members of Congress. And so I'm going to tell two stories about that. But the thing about these stories, and you'll see this and I tell them, is someone asked me, I actually was at a class at State University of New York at Albany, where this teacher was using the book in the class, and someone says, well, can grassroots work be effective? And the answer is yes, if it's done strategically. If you're just out there on your own, writing a letter, talking to a member of Congress, for anything that's, or state legislator, even a city council person, if it's a small thing, maybe, but if it's anything big, one person by themselves, no. But if you organize together and strategically, you can have a huge impact, and that's what we did in an enormous level at HCAN. So with that, let me tell you two stories. So in Congress, there's two kinds of people that you're hoping to move. There's folks you're just not going to get to. But there's people who are, you hear them called the swing legislators, swing in the sense that you're not sure which way they're going to go. And then there are people who are supporters who are going to be on your side. And we had two goals at Healthcare for America Now. One was to convince some key swing members to vote with us. And two is to turn supporters into champions. And I'll talk about each story. So let me start with one member of Congress who's no longer there, but she was a woman named Melissa Bean, who represent suburbs outside Illinois. She's probably the most conservative Democrat north of the Mason-Dixon line. We were going to try to, working with Citizen Action Illinois, to get her support. And one of the things we did is we realized that, and we learned a lot from what happened in 1993 and 1994 when the Clinton plan was defeated. And one of the most effective lobbying forces against it was the National Federation for Independent Businesses, which allegedly represents small business. I say allegedly because most of their positions actually benefit big business, not actually their own members. Very ideological, but they still have small business members, and their opposition was a problem. So we actually created our own small business organization called the Main Street Alliance. And we did it using the same way that those of you who have had your door knocked at as a door-to-door canvasser, or maybe been a canvasser, we decided we'd do the same thing. We would hire people to go door knocking at small businesses. And one of the places we wanted to do it was in the district of Melissa Bean, because we wanted to try to find people, and so we knew she would be responsive to small business voices. And so one of the people we hired was a young man named Jamie Murdung, and he was going door to door, and one of the doors he went to was a store that sold trophies and things like that. You know, you could buy for your sports team or award ceremony or something. And the owner was a guy named Dan Sherry. And he hit Dan Sherry just the right day. Let me tell you why. Dan had gone into business a few years ago, and actually was another business that was selling pet tags. And it's actually his wife's family's business, pet tags, you know, for your dog. And this is a family business, and he went into it with his wife's family business. And 1 month, they got this crazy order for 100,000 pet tags that had to be filled in a month, which was like nuts for this small business. But they did it. They put everything down. They got it. And that was August. And then in September, he realized he had to send his health insurance payment in. And he realized he was so busy in August, he forgot his health insurance payment, which he'd never done before. And he has health insurance, a high deductible plan that he'd had for 15 years. He actually never used it because it was a really high deductible. Even never used it when his 2 daughters were born. So he sent the payment for August and September to the insurance company, and they sent a check back and said, we won't take it unless you have a medical exam. Now, Dan was real healthy. He'd actually been in a marathon the year before, but he'd also been the doctor the year before, and he had elevated cholesterol. And the insurance company said, we're not going to insure you. We'll insure your wife, we'll insure your kids, we're not going to insure you. 15 years of payments, never used their services, we're not going to insure you. And he was really, really freaked out, and he started investigating what he could do. And the day that Jamie Murdung knocked on his door, he had been to his lawyer that morning. And his lawyer said, if you want to protect your wife and your 2 daughters from what could happen if you got really seriously ill, there's only one thing you can really do to protect them financially. You know what that was? To get divorced. So Dan was feeling really awful. Jamie knocks on the door with a petition about organizing for health care reform. And Dan had never been political, never been involved, but signed the petition. And when Jamie said, we're having a meeting this Saturday at a local church to organize, to do something about it, to try to get our local congresswoman on board, Dan went. And Dan said he'd never been to something like this. He wasn't sure about the people. Who were these people? And there were people that Illinois Citizen Action and Main Street Alliance had organized. There were people from churches and Democratic clubs and senior citizen groups, all these different organizations. And Dan didn't understand a word he was saying, but he told me later, sometimes in your life you just have to say yes. So he became involved. And what they did as a group, this group of local citizens that came together, was they started doing what we were telling people all around the country to do, which is we want you to just be there every single weekend, every place Melissa Bean goes, go to her office, go where she'd be there all the time. So she would do this thing where she would send robocalls to a neighborhood, say, I'm going to be at the local supermarket to meet people and talk about problems. They'd all be there. There was a parade she was going to be in. They showed up and said, oh my God, you're here again. And they would meet with her staff every weekend. But she didn't want to meet with them. She was scared of health care reform. She was very conservative. She was worried about small business. She was worried about things. She was scared of it. She kept putting them off. Until August of 2009, when the Tea Parties organized these very aggressive, oftentimes ugly demonstrations and meetings at Democratic town hall meetings. And then Melissa Bean knew she needed help. And so she called Dan and the other folks he was working with and said, can you help me? And that changed the whole relationship. And at that point, when the Tea Party folks held a demonstration outside her office, the HKN, Citizen Action Illinois, Main Street Alliance folks were there. They heard that when Melissa Bean was going to speak at a local chamber of commerce, and they heard the Tea Party folks were there, so at 7 o'clock in the morning they all got there. And they basically, and then they started meeting with her. It turns out that Dan's daughter went to high school with Melissa Bean's daughter, and she heard her story. She talked to him, small business guy. You know, it's not some radical guy. This guy just wants to have security for his family and affordable coverage and not live in such a crazy system. And she did something in November 2009 that no one in Washington ever thought she'd do. She voted for the legislation. Now, Dan was very transformed by this. He got to do some things that most people are transformed that don't get to do. His story is so compelling that when Nancy Pelosi announced the Affordable Care Act, she actually brought him to the steps of the Capitol in the U.S. to talk about it. And he went to a press conference where President Obama was, and he said, "I'm from Illinois," and President Obama said, "Oh, homeboy." So, you know, he had to do some fun things. But there's great quotes in the book about how this personally transformed him. The sense of having a voice, the sense of making a difference, totally transformed who he was. And that's what organizing is about, and that's how you make change. So that's one story. So here's another story about how strategy and organizing fit together. So how many of you can see the picture of when President Obama signing the health care law, and he's sitting at a desk, and there's all these folks behind him, Nancy Pelosi and Harry Reid and all these other folks. And on his right, there's this cute little black kid. You're nodding your head, white shirt, black vest. Some folks have seen the picture. You've got to go look. It's adorable. All these pictures, by the way, are on the website for Fighting for Our Health. It's fightingforourhealth.com. So how did Marcellus Owens get there? What the historians will say is, well, he was there because his mother died prematurely because she didn't have health insurance. True, but not the story. Here's the story. First of all, why were we focused on Washington State? Marcellus is from Seattle. It's because the U.S. Senator there, Patty Murray, is the fourth-ranking Democrat in the Senate leadership. And she was one of those supporters. We always knew she'd vote for reform. We needed her to become a champion. And champions were important because the legislation was going to be under huge attack from folks who didn't want to see it happen, and also lots of people lobbying to weaken it, say it's okay if it happens, but we want to have a special favor here, special favor there, We needed champions who would stand up to that, and also when things got really tough would say, we're not going to give up, we're keep fighting. Patty Murray didn't want to be a champion. She just wanted to get along, keep her head down, and vote, not get involved in this big controversial thing. We had to make her a champion. And so working with the Washington Community Action Network and the HCAN Coalition in Washington, they decided to have a big rally at the end of May. And they started this in January to try to organize their own coalition, get people excited about health care, and to do a big public event, and to try to get Patty Murray there to convince her this was important. And it took a huge amount of work to get her there. I mean, if you read the book, there's like incredible calls and meetings and weeks, and for months to try to get her there. And she was just didn't want to be involved with the issue. She was scared. Finally, she was so well organized that 2 weeks before the rally, she agrees to come. And she's actually very impressive. They expected 2,500 people. There are 5,000 people. It's a beautiful day. They're streaming down this hill in Seattle where the big rally is held. And she speaks, and she's very eloquent in her support of why she's there. Part of the eloquence was because of the crowd in front of her. Part of it is because of what just happened to her behind the stage before she went up, where she met a young boy named Marcellus Owens. Now let's step back. Marcellus Owens' grandmother is named Gina Owens. Gina was canvassed also by a door-to-door canvasser who was organizing for Washington Community Action Network, at that point on nutrition issues. And Gina worked at a community service center, had food kitchen and all, and got interested in these issues, and she volunteered, and she became very much part of Washington Community Action Network, became part of the local board, active, and then WashCan, this organization, began to work at healthcare issues. There was a testimony in the legislature in Olympia, the state capitol, about working people who didn't have health insurance. And Gina got her daughter Tiffany to testify because Tiffany was working in the Jack in the Box and worked there a while and didn't have health insurance. And Tiffany became involved. Well, Tiffany also, good worker, got promoted at Jack in the Box, became a manager, got health insurance, and then she got very, very sick. And she started missing work and missing more and more work because she was too sick to work. And you know what happened. What happened? She got fired, right. And she lost her health insurance with her job, and she couldn't go to the hospital when she needed to. She couldn't afford it. She finally ended up in the emergency room in the hospital, and she died. She's one of the 26,000 people every year who die because they don't have health coverage, these kind of stories. And in the hospital after her death, the family was sitting around, and Marcella said, I want to follow after my mommy and my grandmother. I want to be an activist. He was 7 years old with two younger sisters. Well, the folks at Washington were a little skeptical, but okay, and started having Marcella speak to groups of other young people, and he really just natural for this. And so he was still doing this, and he was going to speak to this whole rally. And behind the stage, as Patty Murray was waiting to speak, Marcellus is there, and Marcellus asks his grandmother, where's Senator Murray? And his grandmother points her out to him. And he walks up to her, and there's this great picture on the website where you see he's doing this sort of raspberry-colored T-shirt, and she bends down and takes his arm, both her hands, and he says to her, I'm here because I don't want anyone else to die like my mommy did. And totally got to Senator Murray. And she then becomes a champion. And she then really becomes a fighter. And she also brings Marcellus to Washington to have a press conference with the Senate leadership and to tell his story and under the national limelight. And he then gets him and particularly his grandmother, because they're not going to attack a 10-year-old, but Glenn Beck and Rush Limbaugh viciously go after his family. And he just, there's a great story in the book. He says, remembers a lesson from his mother, just sort of shrugs it off. So then the law gets passed. Him and his grandmother are home on Sunday. The bill passes on Sunday night. Signing ceremony will be Tuesday. And home on Monday, he says to his grandmother, I wonder if the White House will call. Sure enough, the phone rings. And they take the red eye to Washington that night. And there's a great story in the book about how he ends up with the same color tie as the president. So those are the stories of how change is made. It's strategic. It's organizational. But it comes down to individuals who are organized, who become part of a community, whose voices get raised, and can make a difference. And there's so many members of Congress who voted for the legislation, even though they knew it might mean they would lose their jobs. And that's usually the thing all politicians care about. But because they had seen those relationships with people, because they understood what it was meant, they understood the historic import of this legislation, they voted for it anyway. And it was key to it becoming law. So now let's flash forward to what happened Tuesday, which is after two things we really didn't anticipate. One was, particularly the first one, Supreme Court challenge to the election. Those two hurdles the Affordable Care Act has leapt over. And now we really are in a new era in healthcare in the United States. And let me explain why we're in a new era. Because the law is not a huge change. It's built, it was designed, the only way it passed was to be just enough change to set up a framework to provide affordable health care to most people in the country. But if we change too much, both the industry groups would hate it and the public would even be more scared, and they've already been scared by all the lies about it. But to get it passed, so you say, why is this a new era? It's a new era because the question switches from whether the government has a responsibility and obligation legally to make health care affordable to how it will do it. And all we're going to see now is a regular stream of debates like we continue to see around Social Security or Medicare or Medicaid or any other government program about how to do it. And can you improve it? Should you cut it back? Should you strengthen it? But it's the part of democracy and government, and it's between popular interest and special interest. That's what changes. It's now part of the law, and it's going to go ahead. So let me explain to you quickly what this law does in a very simple way, a couple things in Michigan, and then we'll take questions. So one way I like to explain it is, and this is much more fun to do it this way, but it still works before Tuesday, is there's only one state in the country now where if you lose your job, you don't have to worry about getting affordable health coverage. Or if you want to start a small business, you know you'll be able to get health coverage. Or if you're out of work and you have a serious pre-existing condition, you'll be able to get coverage. Or if you want to retire early or you're forced to retire early, you'll be able to get coverage. What is that one state? Massachusetts, right. The irony, of course, is that in his closing at the last debate, Governor Romney bragged about the fact that 98% of people in Massachusetts had health coverage. Right. Anyway, we can forget him. The point is Massachusetts is there, and he may be a footnote in history in terms of Tuesday, but he actually has an important role in history because he did sign that bill into law, and Romneycare is the model for Obamacare. There's lots of problems with the healthcare system, and they're going to get addressed over time, but the one that's most pressing for people is that there is this tremendous sense of health insecurity, that all the things I just talked about are true, that 60% of the personal bankruptcies in the country are related to healthcare costs, and that this sense that, well, we have so much we spend in healthcare in this country, we leave so many people out, and it creates this enormous insecurity. And one of the reasons the law is not understood is because the key provisions of the law that address that don't go into effect until January 1st, 2014. And so people know it passed, but nothing's changed. Now, there's some things changed if you're like she wasn't, like my daughter until recently, she was under 26, had health insurance. So a few things have changed. There's some 6 million young people like that. If you're a senior citizen who's paying for prescription drugs under what they call the donut hole, which is a thing where you keep paying your premiums but you don't get your drugs paid for, that's being closed. There's free preventive care and private insurance now as well as Medicare. Health insurance policies no longer can stop paying if you're seriously sick, put artificial caps. So some things have changed. But the big thing, this sense of if I lose my job, if I don't have coverage at work, how do I get coverage? That will change in January 1st, 2014. And the system, as I said, it builds on the current system. Most people, it's not going to be any different. Most people get coverage at work. About 150, 160 million people get coverage at work. That'll stay the same. There have been some improvements to that coverage already. No more lifetime caps on payments, diminishing, and as next year, no more annual caps on payments. So if you get a serious illness, serious accident, your insurance company will have to continue to pay as opposed to say we're not going to pay anymore. You still need the health care. You're really ill, but you've used $250,000. We don't have to pay anymore. That's ending and ended. But except for that, and as I said, private insurance will now cover preventive care without out-of-pocket costs. So there's some improvements to your health policy work, but most people will be the same. Now, for low-income people, we have Medicaid in this country. But it's, except for some groups like pregnant women and kids, it's up to the state how much, up to what level, poverty level, the states cover Medicaid. And it's all over the place. In some states, like my state in New York, it's up to the poverty level or even up to 1.5 times the poverty level if you have dependent kids. In places like Texas, it's 25% of the poverty level. It's like, which is like crazy. I mean, so it's going to raise that to 133% of the poverty level, which is about $30,000 for a family of 4. And in Michigan, assuming the state does it, and the state's very likely to do it, the only thing that was bad in the Supreme Court decision, it gives states the option. That will mean that between 450 and 600,000 people in Michigan will get covered. These are working people who don't get coverage at work, oftentimes working minimum wage jobs, 2 or 3 jobs. They'll get covered. And the cost of the state, the federal government's paying 100% at the beginning, down to 90%. You look at it 2 ways. One is 30% more people in Michigan will be on Medicaid. It'll cost the state 2% more. Or there's a study just done by a policy group in Michigan that says when you look at the actual savings over 10 years, it'll save the state $1 billion because the state won't be paying for a lot of mental health care it's paying for now, and also for a lot of prisoners who will be able to get Medicaid. So the point is, big expansion of Medicaid. A lot of working families will be covered, a lot of individuals covered who are low income. So that leaves the people really who don't get coverage at work, make more than 1 1/3 times the poverty level, and that's where the new innovation comes in. These healthcare, they're called exchanges, marketplaces, where you really get health coverage, but from private insurance. But right now, the individual market doesn't work because you get denied care if you're a pre-existing condition, you get charged more if you're sick, you get charged more if you're a woman, and it's very, very expensive, and most people can't afford it. Under this new system, through these exchanges, these marketplaces, there'll be established levels of benefits. Basically, there'll be a standard set of good benefits in all the plans, so it won't be skimpy care. If you pay higher premiums, you'll have lower out-of-pocket costs, but they'll all have good benefits. And the cost will depend on your income. It'll be subsidized so that you'll be limited based on your income how much you'll pay. And the subsidies, there'll be tax credits, but you get them in advance. You have to worry about paying it and getting it back. In effect, that's why it's better to call them a subsidy, although technically it's a tax credit, but it's advanceable. We'll go up to families of 4 that make up to $90,000. So it's for working families, middle-income families will get subsidies. And the more you make, the higher percentage of your income you have to pay, up to about 8% of your income. So, but less for folks who make less money. And there'll be a requirement that you buy coverage unless it's deemed unaffordable, more than 8% of your income. And if you don't, there'll be a penalty. But the point is that way you get in the system. It's affordable because it's based on your income. And it's working very well in Massachusetts. As Governor Romney said, 98% of people are covered, 99.5% of kids are covered. So that's basically the system. It's that simple. It's new for people because we don't see it yet. And it's hard to imagine if you haven't lived with it. But it's really, that's the big change. There are some other changes coming that deal with the problems of healthcare costs. And the law does do things to start addressing healthcare costs. Mostly by trying to get hospital systems to work with doctors to focus on quality of care, not quantity of care. And let me give you one example, and then I'm going to take some questions. There was a few years ago, Beth Israel Hospital in New York started a very good community diabetes prevention project, where they would actually work to reduce diabetes in the community by getting out and doing prevention, early intervention. And lo and behold, it worked, and fewer people got admitted to Beth Israel with diabetes. And so they had to stop the program because they were losing money. It's a true story. That's crazy, right? Totally crazy. So what the Affordable Care Act is moving to, through Medicare to start, but more and more health systems are looking at it, is a system where the hospitals would get a payment to care for people, and if they kept the people out of the hospital, they'd still keep the money because they save money by getting preventive care. And hospitals can do this in a community, work with more and more people in the community, have prevention programs, and try to improve the quality of care so that providing better care as opposed to more care pays. And the best hospital systems in the country, like Mayo and Cleveland Clinic, do this kind of system. Doctors are in salaries in those places. The new law doesn't speak to that at all, but it makes much more sense for a doctor to be on a salary. They get paid well. They don't worry about liability insurance. They don't make as much as the most highly paid specialists, but they still get paid very nicely. But they're focusing not on, I got to see a patient every 10 minutes because in order to pay the bills, but in effect, I'm going to figure out working with a team of physicians and other practitioners, nurses, PAs, a lot of the folks that early staff trains how to provide better health care. So that's the direction we need to go to in this country. I mean, lots of push and pulls. You're going to see, and there are problems with the law. Sometimes the premiums are still going to be too much. Sometimes the health care costs can be too much. For people who work for large, low-wage employers, they may still be stuck between their employers and not getting the exchange. There are problems. We're going to, like we do in everything else, we're now going to address those problems because we get people enrolled. A lot of people are going to like it. It's not going to work so well. Some people say, scrap the whole thing. We have to organize the Dan Sherrys, the Marcellus Owens, and all those people are benefiting it or could do better. to raise their voices, to even strengthen as we go forward. That's the newer era in, and it's the promise where Marcellus Owens can say, yes, I don't have to worry anymore, like people dying like my mommy did. So with that, I'd love to take your questions about anything you like. Go ahead.
I have a question about the Medicaid provision, the expansion of the population covered by Medicaid. It would seem that it would be very much in the interest of business, industry, everybody within the state to have this population covered under Medicaid, because business and everybody else is helping to share the cost of unreimbursed care for them.
Right.
And yet the leaders of some of the red states are saying that they're not going to go along with that. How do you see that playing out in light of the incentive they have to get health care money in their states?
Yeah, I don't think it's going to last long. I mean, you're right. Having all these uninsured people, so you're uninsured, eventually you end up in the hospital like Tiffany Owens did. It costs a lot of money. But $1,000 of the average premium that people pay is for people who end up in the hospital without coverage. Hospitals, and insurers, and doctors and nurses would much rather have people covered. So it's, on a human rights point of view, it's pretty clear, but on an economic point of view, it's also really clear. And then when the state's going to be paying the most 10%, and you're getting zero for it, why would the state send its taxes to Washington and not get it? So the opposition is purely ideological from Republican governors who want to oppose Obamacare and also don't like Medicaid poor people. But you saw just this week, one of the leading Republican governors in that category, Rick Scott in Florida, is starting to backtrack. And it's important to remember that every state in the country does Medicaid. Even though Medicaid, like in Michigan, Medicaid pays 66% on average of the federal government does. Michigan's paying a third. So and in most states it's around that. It goes from 50% to 76%. Most states it's in between. So if states are doing it for that much, why wouldn't states do it when they're going to get the most 10%? So you're right, it'll take a while. Governors resisting it are going to be unpopular because there's going to be a lot of pressure from both uninsured, the sandwich people, uninsured people who aren't real low income, the low aren't the poorest on the exchanges, and the hospitals to say, let's just do this. Good question. Other questions?
Think there's a chance for this to morph into single payer?
So for those of you who, single payer is a term that's used for the kind of national health insurance that they have in Canada or that we have in the United States for people 65 and older and people with disabilities. Medicare. It's called Medicare in Canada. It's called Medicare here. It's basically where the government is in fact, the insurer, although in the United States it's administered through private insurance companies. For me, that's actually not the interesting question. What's interesting about, so people talk about what's going on in other countries. The United States is the only country in the world which doesn't have, sometimes you hear single payer. That's actually not true. Canada is like one of the only countries in the world that has single payer. But what every other country does that we haven't done, and we've taken a huge step, not all the way, but a huge step with the Affordable Care Act, is to say that healthcare is organized not as a commodity, but as a public good, as a right that everyone should have. And the reason, by the way, we have the most expensive healthcare system in the world, and the most inefficient from an economic point of view. Economics is what you get, you pay for. That's what value is from an economic term. We get the least, we pay the most, 37th in quality, all these things, is because we've treated healthcare as a commodity and because we leave lots of people out of the system. So we've made this major step to solving that. Over time, I believe more and more that will happen. More and more, a lot of employers will think, why don't we just use the exchanges as opposed to providing ourselves? We'll pay our employees more money. That won't be true for higher wage employers, but you'll see for more and more for moderate wage employees. More and more to control healthcare costs in the system, we'll do what other countries have done. We'll take the kind of steps that we're taking already in Affordable Care, we'll accelerate them. How is it that, as those of you know, that drug prices in Canada are half the prices here? But who gets the lowest drug prices in this country? Do folks know? The Veterans Administration. The VA does what every other country in the world does. they basically, negotiate's a nice word for it, they basically tell the drug companies, this is how much we're going to pay. The drug companies, okay, you have a big market, we'll pay that much. Pharma's lobbying power is so much to stop that, but they won't be able to resist that forever, because when the public as a whole is paying for this, at some point they're going to say, we're not going to continue to pay these crazy rip-off prices to pharma, to the drug companies. So my answer is, we will see a system where more and more healthcare is a public good, more and more we're being sure that we're paying for quality, not quantity, and we're not doing that through a market because it doesn't work for healthcare. It'll be our own system, like Canada and England and Germany and the Netherlands and France. They each have their own systems. It won't be single payer, it won't be the Affordable Care Act. It'll be an American solution, but it'll be more and more in the spirit of what's true in every of those countries, which is healthcare as a public good and a human right. And that'll make healthcare more affordable, not only as well, which is one of the wonderful things about it. Yeah. Go ahead, yeah.
First off, I'd like to say thank you for presenting to us. Since we were cool to get some information on the Affordable Care Act. Secondly, my question is it true that the Democratic Congress voted to exempt from this act?
No, just actually the opposite. This is actually a really funny story. So in the Senate Health, Education, Labor, and Pensions Committee, which is one of the Senate committees that was considering the act, Republicans decided to be clever. And they put up an amendment that said every member of Congress had to go into the health care exchanges and the public, and they thought that would embarrass Democrats. And Democrats said, okay. So the law actually says that members of Congress are now going to be getting health care through these exchanges. Instead of getting them through the federal employees' health care benefits, they get it now, like other federal employees, they're actually going to go through the exchanges. So one of the most popular things you can say organizing is, you want to get the same, you should get the same health care as members of Congress. Well, now members of Congress are getting the same health care as all these people in the exchanges. So the exact opposite of what that, one of those many rumors, lies, scare tactics, whatever you want to call them are. Sure. Other questions?
What do you know about our state as, because they did not, as I understand it, they did not set up anything for the exchanges as yet.
Right. So what I understand, and Linda can fill in, so Governor Schneider wanted to do an exchange. The Senate leadership said yes, but the House leadership didn't. And the fallback then, so there's the states, if states don't set up these exchanges, the federal government will. And they've developed this new kind of partnership where the federal government does it, but states can do things like manage the insurance companies, do community outreach. And so the latest is, although this still could change, but we'll know by Friday, is that Michigan is looking to do a partnership where the federal government would set up the marketplace, do the online stuff, but then folks in Michigan would help with like community enrollment and things like that. That could change, though, because by Friday, the governors who haven't done so already have to say if they want to set up an exchange. And so I wouldn't be surprised if the governor is trying to lean on the Republican House leadership and said, okay, the election's behind us, why don't we do it ourselves? So you'll know on Friday whether or not you're going to have Michigan doing it or doing it as a federal partnership with the government. Sure.
It's a huge holiday on Thursday here, though. It's deer hunting season.
Yeah.
The legislature does not meet, so the governor's sort of up against
Yeah.
a bit of a
Yeah, but could he, if the House leadership indicated they wouldn't oppose it, do you think he could go ahead and write the letter?
I think that's really interesting, given what's taken place in the House of late, with the Speaker's position is somewhat in question. It'll be sort of interesting, but I think that you're going to see it on.
You see the partnership, you think. Well, Linda knows she does this work right here, so that looks like that you'll end at the partnership. And I think that's actually, I mean, from my point of view, I don't want states to do it unless states want to do it aggressively. So the exchanges can do a good job. Massachusetts actually is a great model. They've done one thing they've done there is the governance of the exchange, no one who makes money off the healthcare industry is allowed in the governance. Can't be a doctor, a hospital, insurance company. It's only business, labor, and like consumer reps and experts. Most states aren't doing that, but that's another thing done in Massachusetts is they actively negotiate which plans are allowed, which insurance plans are allowed in the exchange. They want to be sure they're plans that have high quality at good cost. So I'm interested in you could do an exchange where the people who run the exchange come out of the insurance industry. They let any plan in. They don't monitor costs or quality. I worry that that'll happen in states with governors who are tied to the industry, don't like this. So, it may well that it's better for a lot of states to actually have the federal government do it, and then states play perhaps a role.
How do you see us handling the issue of all of a sudden we have all these people insured, but we don't have people to provide?
I should ask Dean Early to talk to that. I mean, it's a huge challenge that there's going to be a lot more people getting primary care, and we don't have enough primary care providers. There is some money in the Affordable Care Act to do that, to pay more for Medicaid primary care providers, to do more training of primary care providers. But yeah, it's going to be a problem that you're going to have covered access. Do you want to add anything? Okay. Well, you should add. So you may have ideas. Do you guys want to?
Yeah. Oh, I have ideas.
Good. Well, do you want to tell people what the idea is?
I think that we're throwing good money after bad to think it's all going to be physicians that take care of this kind of thing. When we know and we have the data that support the fact that mid-level practitioners are really good at this kind of thing, both nurse practitioner and PAs, and that we need to work as teams because there are very few people that need only one kind of care. I hope that we'll set up systems that encourage teams of people to take care, teams of providers to take care of people, but I'm not sure that's really on the agenda of policy right now.
Well, first of all, my daughter is a pediatric nurse practitioner, so you're talking to me right in my heart. And I mean, I do think, and I'm sure you see this in the fact that most of your graduates are probably finding jobs pretty easily. There is more and more acceptance of mid-level practitioners in practice, more reliance on them. I think that will continue to really accelerate as we bring more people into the system. And also as we build these healthcare systems where you can understand that it doesn't make sense. You can buy, actually, I think usually better quality care for mid-level practitioners in my personal experience for primary care. And it's a shorter track to get people in. It's 2 years instead of 5 years and everything else. So I think we'll see more of that. But it's going to be an issue for sure. Someone else, but go ahead.
Who will be the people who won't receive health care?
Good question. So law does not cover people who aren't in the country legally. 11, 12 million people, depending on your count. It will be interesting to see, though, as we're about to, looks like one of the things the election is we're about to take a fresh look at immigration reform, how the question of health care plays into that. That would be one group. Another group will be, because it's not a real universal system, like everybody gets enrolled in Medicare because you kind of know at 65 you're in Medicare. But because it's still not exactly patchwork, but still not a good simple system, there'll be still people who don't low-income people who don't enroll in Medicaid, or people who get caught between Medicaid and the exchanges. One thing is supposed to be one application for Medicaid in the exchanges, but there'll be people who just get caught, just don't apply. There'll be people who actually are allowed out of it because they, as I said, if you're upper middle income kind of, so your subsidies go up to $90,000 for a family of 4. If you're above that and you pay more than 8% of your income and you're not required to get coverage, some of those people won't. And there'll be people who actually decide, even though it's percentage of my income, it's still too much for me, it's not worth it, and they pay the penalty rather than get covered. Again, now Massachusetts, we're up to 98%. I don't think we're going to do that well nationally. Massachusetts is a state which started with a lot of people insured, with a high percentage of employer-based coverage, It's a more liberal state generally. But the projections are nationally we should be at 94, 95, and we'll do better over time, particularly if we get more people enrolled. So for me, the most exciting thing is let's get lots of people enrolled. Enrollment starts October 1st of next year. Other questions? Right here.
Do you think the accountable care organization approach is going to take off? Are hospitals going to grab onto it, or communities?
Yes. This, again, the accountable care is the name for these networks I was talking about, hospitals and doctors, and hopefully we're employing a lot of other mid-level practitioners and all working it. Yes, we're seeing tremendous interest in it and lots of talk within the health delivery system and just practitioners about it. I think they are going to take off. And there'll be all sorts of different levels, and there'll be gaming of the system. Insurance companies want to start like buying these because they see the future. I mean, in some ways, you don't really need insurance. I mean, you don't really need insurance companies, which a lot of us know. But if you basically have everybody enroll, everybody, in effect, if rather than an insurance company, if you decide, you know, there's a big accountable care organization, which is basically the practitioners and the hospitals in your community are in one or two systems of care that are getting, if you enroll them, they get a certain amount of care for you, then there's like no, except for paperwork, there's not a single function left for an insurance company. So they're starting to say we better look at buying some of these things so we still have a future. Go ahead.
I'm loving all this, and soaking it all in, and I just am hoping this is just a projection. Are the hospitals going to get enough money? Because I think right now some of the concerns are, do we have enough nursing staff? Okay, I'll speak for the nurses. Do we have enough nursing staff? Can we increase the number of nursing staff to care for all these people that we now can,
Right.
care for? I know hospitals are usually pretty darn full, in capacity, at least in their community, but I also see sometimes that there's always a need for more nursing to care for these people because of the nurse-to-patient ratio. And I think some of the concerns that some of the hospitals have are, we can't afford right now to hire more nurses. And that's something that I just would like to know, or just dream for, or whatever. Is this going to help make sure that the hospitals get enough income that they can support the system?
So, I mean, these are going to be these are the struggles in this country now. They're the struggles all around the world. How do we use our healthcare dollars in the best way? I hope the conversation switches, though, not to like, oh, these people are out of the system, so we don't even deal with them, to everyone's in the system, so how do we do it in a better way? I mean, again, what's going on in Massachusetts is very interesting here. So one of the theories we always had was if you get everybody in the system, you'll start controlling costs. And one of the reasons it's so expensive here is we leave too many people out of the system, and then costs get shifted out. So here's what's happened in Massachusetts since the law was passed. So now the state is on the hook for these subsidies. And it's been concerned there more about cost and premiums going up. And so Governor Patrick has leaned on insurance companies and said, we're just not going to approve your rate increases anymore. Now, while the insurance companies obviously contribute to high healthcare costs, they're not the biggest drivers. It really is hospitals and doctors and drug companies and medical supply companies. And the hospital said, well, wait a second. The insurance company said, it's not us, it's them. So Partners Health Systems, which is one of the biggest academic medical systems in Massachusetts, a couple years ago said, oh, we can find $40 million to cut. And, they're always screaming poverty, these big academic medical centers. Then the Attorney General of the state does this study that shows that community-based hospitals provide the same level of care as academic medical centers for, the things most people go to the hospital for, not the really rare stuff, but the gallbladder or even the cancer treatment that's been perfected over years. And they do it at a much lower cost. And and she wouldn't have done that study and looked at that if this whole conversation. So the Massachusetts legislature passed a law this year which sets growth targets for healthcare in the state. But the thing that's important about that is it actually allows the legislature to look at contracts between insurers and hospitals. Now, I'm telling you things to control costs. You say, well, that's going to make things worse. Who's going to come out ahead of this? It's got to be people who find ways to provide better, more efficient care. The community hospital that's providing better care, more appropriate care. it's not the academic medical centers where both academic medical centers build the same, high-tech thing across the street from each other. Why should they compete? It hurts quality. The center that understands, let's get people in early, let's be sure they get primary preventive care, so then it makes sense to invest in nurses or mid-level practitioners to do that. Now it sounds great, it's not always going to work out, sometimes it's going to be ugly, sometimes it's going to be the specialist running things like they always have, but you hope over time, and it makes sense over time, and if you look around the world, that's why systems around the world provide better care at lower cost, because once you no longer can kick costs outside the system, there's more incentives to find ways to provide good care. And also, frankly, we haven't talked about it, and it's not, the law doesn't touch this, but, then you start to want to look at more like the epidemic in obesity, which, of course, is like, it costs us $1 trillion in a decade. And that's becomes a real question for the medical system to start looking at, and lots of social things. So again, the logic changes. This is why I call it a new era. Although it's going to be slow, it's going to be painful, no miracles by any means. Go ahead.
Do you anticipate any new job roles or categories, new kind of employment because of the changes in the system?
Well, hopefully you'll see more mid-level practitioners, primary care providers. You'll probably see more people like a job my second daughter has. I think it's very personal, but she got her master's in public health, and she's working for a health quality improvement organization that's working with, so it's Medicare funded. She's working in communities to help those communities provide better access to communities of color, because there's big racial disparities in healthcare, and to design programs to do that. You're going to see more jobs in data management in healthcare to measure what's working, what's not working, where people are providing too much care with no better results. So I think a lot about both better primary care, but much better measuring of results, data-driven looking at systems, and focus on quality improvement as opposed to just let's provide more because we make more money that way.
What about things like patient navigators?
Yes, absolutely. That's a whole other area. Yes, one thing that the law funds is patient navigation. So community-based organizations or others to actually help people figure out how to get enrolled and understand. The organization that I worked for years in New York has contracts already to do community-based education about the new law and everything else. So yes, there'll be those kind of jobs as well.
If you're out of the country, you don't get any help. Is that correct?
It's no different. No, it's not. It's just like whatever your health insurance covers now. Basically, there's no change. If you're
I understand that in Canada, you can give them a little extra money, and if you get ill outside the country, they'll go evac you to Canada.
Maybe, I don't know. Yeah, no, if you're traveling, I think you still have to make, some arrangements to get, of course, if you know, most of the places in the world, if you're traveling, you go get health care, they don't charge you. So that's, but you do want to come home at some point. Any other questions? I know we're almost out of time. Go ahead.
Is there a downside, and I'm thinking of potential downside. Healthcare insurance industry is huge, and so that's a big piece of our economy. Drug manufacturing and distribution is huge, and we're going to pinch that.
Pinch maybe is a little strong. We already spend like 50% more than any other country in the world per capita on health care. These companies are doing very well. They're going to get 30 million new customers. That was part of the deals that were made. Takes less money, you'll get more customers. The real crisis is not for those folks. The real crisis is the economy. The thing that's driving the federal government's long-term deficit, and you're going to hear a lot of wrong stuff about us the next few months. It's not Social Security, which has nothing to do with the deficit. It's basically been the recession And in the long term, the only threat is healthcare costs. And already, because healthcare costs the last 2 years are lower, healthcare inflation is lower the last 2 years than in decades. If CBO started putting that, you'd actually see the long-term deficit projection started going down. So in terms of our ability as a society, businesses to compete, it's hard to compete when other countries businesses don't have healthcare. Other countries, businesses don't pay for healthcare, except a little bit through the tax system, as opposed to companies here, which have to pay the highest. So our ability to function in society, we're always going to spend more than anyone else. It would be better if we spent it more wisely. The industry will still do fine.
I just had to do that.
That's okay. They'll scream poverty, but then you said what happened in Boston. Patricia.
Say, if you would repeat that what we've been told, what has entered the mythology is that the Medicare or these, what do they call them, entitlement programs are what is draining our economy and causing the debt. That's not true.
Well, right now, they're not what's caused the deficit. The long term, the deficit immediately has been caused by, if we'd never done the Bush tax cuts, we wouldn't have a deficit. If we'd done the Bush tax cuts, and also, we put 2 wars we didn't pay for. But the fact is, even if we had done the Bush tax cuts, done the 2 wars we didn't pay for, and not had the recession, then the deficit would still only be 1.2% of GDP, totally manageable. So there's a lot of people scaring people about this. Having said that, if you look at the long term, and Social Security is not contributing to deficit, and easy fix for Social Security is not to quote adjust the cost of living increase, which is actually cut benefits by 15 to 20% for middle income seniors, and Social Security benefits are not generous. If you simply said that right now above $110,000 you stop paying your Social Security, if you lifted that to where it's traditionally been, you could make Social Security solvent to 2075. So there's easy things for that. It is true, though, the growth of healthcare costs is the one thing we do have to get in control. But you don't get it control, and this is the thing. You control by the kind of things we've been talking about this evening. You don't control healthcare costs by shifting costs. So, for instance, the federal government, so you've got this Medicaid proposal, which Republican House budget has passed, which would turn Medicaid into a block grant to the states. Now, basically that means is right now, if you're involved in Medicaid, the federal government pays 2/3, Michigan pays 1/3. But, and if you need more services, that's true. This would instead is, the federal government's going to give Michigan 1 block grant of money, and it's going to increase a little bit with inflation, but it's not increasing if people need more services. So it's not going to save money. It takes it off the federal government's balance, income statement, expense statement, but it doesn't save any money. In fact, it raises the cost because what we've seen is when you actually, so classic example in New Hampshire years ago, they introduced a co-payment for prescription drugs in Medicaid. It raised the cost because people weren't getting the drugs ending up in the hospital. You want to do things to save money. The same thing with the voucher proposal for Medicare. It doesn't say, it saves the federal government money by transferring the cost to seniors, $6,000 more. And it also goes to private insurance, which is as a worse, and this is something people, they don't believe it because it can't be, because private business is always better than government, right? Not in terms of health care. Health insurance under Medicare, health inflation under Medicare is lower than in private insurance. So we want to save money in the whole system, not just for the federal government. It's for the whole people, the whole country. And that's the kind of solutions we need to be looking at. Thank you.